And I'll go ahead and turn it now to Terry to get us started.
Well, hello, everybody. Welcome back to session 2 of this. I guess if you were at session 1 and you came back, I'm glad that you found it valuable. I don't know if, first of all, I hope everybody can hear me, that I'm not just a disembodied voice talking to myself. So we're going to move ahead on starting with where we dropped off last time. So today, this is what we're going to cover, basically who is able to access OAARS, including what data is available to pharmacists. We're going to talk about what is publicly available on our OAARS website, all kinds of reports, interesting facts that you can get, all kinds of data that we do have publicly available, and you can access all of that without even having an OAARS account. And then Kelly's going to jump in and talk about some of the gaps we have both on the OAARS reports and in OAARS usage. It's not a perfect system. We do know there are some gaps. We do our best to address what we can. Unfortunately, we can't address every gap. Next slide, please. So we're going to talk about who may legally access our database and when they may access it and for what specific purpose. Next slide. So Ohio Revised Code 4729.80 specifically outlines who can have access to our database and for what specific purpose they may use that data. Prescribers, which includes physicians, advanced practice nurses, physician assistants, dentists, optometrists that have prescriptive authority, and even veterinarians may request a report on a current or potential patient for the purpose of providing medical treatment to that patient. Veterinarians can only request their patient, like Fluffy or Fido, not the name of the owner. A pharmacist may request an OAARS report on any current patient for the purpose of the pharmacist's practice of pharmacy. I should say current or prospective patient. Prospective is a patient is, a prescription has been called in, a patient is standing there with a prescription and the pharmacist is making the determination, is it appropriate to even fill that prescription at that time? So they don't have to fill it to run the OAARS report. Having the content of that OAARS report is a part of the clinical decision of, is it appropriate to fill this or not? There are about 23 different entities outlined in the law who are allowed to access the database. I'm not going to go through all 23 entities. It's fascinating reading that you're welcome to look it up on 4729.80, but 99.9% of our reports are requested from the people on this slide here for the appropriate purpose. Next slide. So what is an appropriate purpose? For purposes of medical treatment or prescription, so this is for prescribers or pharmacists, they're allowed to look up a current patient or a prospective patient. Prospective, they could have a referral on the books. I have called into my doctor's or to a doctor's office, say I'd like to be seen for lower back pain. A prospective patient in a pharmacy could be one where a prescription is called in, left on, it's a verbal script left, patient's not necessarily there, but the pharmacist has every reasonable expectation the patient will be showing up and they can start working that order ahead of time. So they have, it's for the purpose of practicing pharmacy. There are lots of reasons not to access the database. These are all reasons that are, the reasons you can access the database are specifically outlined in the law. Anything outside of what is specifically outlined is a violation of that law. So like for research purposes, you cannot have, we have doctors who are looking up, patient, they want to look up something like, for example, patients, before they're treated for a condition, let's say a knee replacement. What drugs were they taking before they had their knee replacement? And then, 5 years down the road, what drugs are patients taking for knee replacements? They're not allowed to access it. The doctor is not providing medical treatment at that time for that patient. They cannot look up old history to see what was what kind of history people had before and after. Pre-employment screening. I actually had somebody call me today on this. They had a new hire who came, their their urine test came back positive for a controlled substance. They wanted to run an OAARS report to validate why that patient was on that controlled substance. That is a violation of the law. They're not treating that person. It's not their patient. They cannot use the OAARS report to do that pre-employment screening. Searching for forged prescriptions. If the, excuse me, I have a frog in my throat there. Law enforcement, they can use it for searching for forged prescriptions, but a prescriber cannot. A pharmacist cannot use that for looking for a forged prescription. Requesting a report on a patient who has passed away. The only person who can do that would be the coroner, because that patient is a patient of the coroner, or law enforcement. So, if your local pharmacy is like, I haven't seen, patient Terry in a long time, wonder what's happened to her. Let me just run her OAARS report and see maybe what pharmacy she's going to, maybe she's moved. Pharmacist is not treating that patient at that time. They cannot look up that report just out of curiosity. Next slide, please. So OAARS for research, there are no provisions in the law for an authorized OAARS client to obtain patient-specific information for any type of research project. I mentioned like that knee replacement earlier. That's a common request. They want to see how they were being treated, 2 years ago versus how they're being treated now. A de-identified data set is available for research purposes, but it will not have any patient data on there. It will not have any prescriber data on there. It's completely de-identified. It's available upon request. You have to have an IRB and a signed MOU, or memorandum of understanding, to obtain one of these sets. If somebody really wants it and they have the IRB and an MOU, they can contact us for more information on the details of getting this de-identified set. It will contain literally millions and millions of line items of prescription data. We will not pre-sort it for anybody. We will not narrow it down for a specific county or a specific physician. It is a complete set, and it's completely de-identified. It's very rare that we actually get a request for a de-identified set. Next slide. So hospital pharmacists sometimes think that OAARS doesn't apply to them. Remember, in our first session, we talked about OAARS is a outpatient prescriptions, it's a list of all the outpatient prescriptions that have been filled and who has to request a patient. It's all based on prior to filling an outpatient prescription. So hospitals think, okay, OAARS doesn't apply to them. We can just ignore everything in there. Well, while there is no requirement to review an OAARS report before dispensing an inpatient prescription, the OAARS report can still be a valuable tool during the medication reconciliation process. Remember, these are their patients. They are treating them. They are making dispensing decisions of what would be appropriate to, what medications may be appropriate or may not be appropriate. So the OAARS report, it provides another data set of information for them. It helps fill in the gaps of what a patient tells you. I know there were several times I would take my dad to the emergency room, and for whatever reason, and the nurses are asking him, what medications are you on? He's in a state of, I'm uncomfortable, I may forget something. The OAARS report helps fill in some of those gaps. He could say, I'm on a pain medicine, but he may not remember the name of that pain medicine. So that OAARS report helps fill in the gaps. It also helps validate what the patient tells you. If they say, I'm not on anything, I've never taken anything ever, and then the prescriber runs an OAARS report and they see all kinds of information, okay, do they have the right patient to start with? Or there's something not adding up? But that report does help, help them make a clinical decision along with the clinical presentation of that patient. Prescriptions that are filled to the patient on discharge for them to take home. So patient Terry is still in the hospital. I'm having my discharge meds filled. I'm going to take them home with me. Those are outpatient dispenses. Remember, pills that go home are outpatient dispenses. So yeah, the hospital would need to run that OARS report. It's an outpatient event. A lot of hospitals will fill their employees' scripts right there. That's an outpatient event. You know, hospitals sometimes forget, hey, it's not where they're standing, it's where the drug is going. So, you know, hospitals do have a need for OARS and an acceptable use to use them as well. Next slide, please. So in the pharmacist OARS roles, we put a reminder in there that pharmacists have a corresponding responsibility regarding the validity of a prescription. A pharmacist is not required to dispense a prescription that's doubtful, questionable, or suspicious origin. They are also not required to, even if it's not doubtful or suspicious, a pharmacist is not required to fill every prescription that is presented to them. Maybe looking at that OARS report, it's like, well, they just got a 10-day supply of this medication 2 days ago. To fill it now, again, may be inappropriate. So pharmacists can say no, and they can use the OARS report to support why. Let me start that sentence over again. They can use an OARS report to help support why they are declining filling that prescription at that time. It doesn't, the OARS report will not say, do not dispense. Maybe the pharmacist needs to have a conversation with the prescriber. Might be an early refill because the patient's going on vacation. So there's no absolute yes, fill it, don't fill it, but the report gives them that added information, and a pharmacist is allowed to say no. And it's right in our rules that says they are allowed to decline filling a prescription. Next slide. So we're going to talk about the content of a patient's OARS report. Next slide. So all this information, you have this huge database, where does it come from? So OARS is it's a list of all prescriptions filled from an outpatient pharmacy to an Ohio patient. So every pharmacy in Ohio, they report every reportable prescription to us. Remember, that's controlled substances, gabapentin, and naltrexone. We don't collect antibiotics. We don't collect blood pressure medications. If the pharmacy sends it to us, we're not going to decline it, but all they're required to report are the controlled substances, gabapentin, and naltrexone. So all these different prescriptions come into our database literally every day. We get tens of thousands of scripts from thousands of pharmacies every day. So all this information comes in to the pile and it funnels through into the patient OARS report. Next slide. Now, the next few slides, I'm going to describe the contents. It's easier if you can see a report, which we'll get to in a couple of slides. So bear with me here, okay? So what's on an OARS report? The first section of it is called NARCS Care. And NARCS Care is an add-on to every OARS report. It's something that our vendor supplies. The state of Ohio has made the commitment to include this with every report, not every state. Every state has this option to include it. We have made the commitment, we are going to do that. So we've had it now for about 4.5 years. It is available on reports that you pull from the website, as well as any integrated systems that are out there. It shows up on every report for prescribers and pharmacists. It will not show up on the law enforcement account. They don't get access to the NARCS Care. The line item prescription detail from the report is taken and put through a series of algorithms to create risk scores, identify potential red flags, and potential is emphasized. It's what may be potential, or what we say is a potential may or may not pan out as a real red flag. Neither OARS nor NARCS Care will ever tell a prescriber or a pharmacist, will never tell a prescriber to prescribe or not prescribe. It will never tell a pharmacist to dispense or not dispense. Those decisions are part of the professional judgment and corresponding responsibility expected to be used with each patient encounter. Next slide. So The NARCS care, this is kind of what it looks like. You have your Betty test patient. She is our generic patient that we use for training purposes. And this NARCS care adds analytics to the patient's OAARS report. Many tools and hyperlinks are available to offer explanations and guidance along the way. And in the upper right-hand corner, it has the additional risk factors, which may be something like multiple prescribers, but the multiple prescribers will not account for prescribers working in the same office sharing a common chart. So just because the patient has been to 4 different doctors, is that a problem or is it not? The system isn't smart enough to say, hey, these guys are all working from the same chart, because doctors work in multiple offices. We don't know from which office a patient was actually seen. It's just saying there are 4 prescribers. Some prescribers have more than one DEA number. And if a pharmacy fills it under DEA number 1, and another pharmacy fills that same doctor under DEA number 2, that's going to show up as 2 different prescribers, even though it's really the same person. So those additional risk indicators, it's a possibility, but it's not gospel that it's a problem or not. You have to look at the prescribers, and if you see they are all from the same office, or if you know they're all from the same office, or that one is a general practitioner who is referring somebody to an orthopedic surgeon, if there's a relationship between them, those are key factors to consider. So the report itself doesn't tell you everything. You have to have those additional conversations with the patient, maybe have to do some more digging. But the top of every report will show these, potential risk factors. Next slide, please. So next we have, it's a chart. Some people really like charts, okay? So NARCS Care will take that line item detail and they place it on a time graph, and it's color coded. So all the narcotics are red. So you'll be able to see, for example, on line 6 here, prescriber Janice Johnson, she's doing, all the different, she's doing a bunch of different narcotics, and the time frame that, when did that patient have a prescription for that item. So it makes it really easy to see overlaps or gaps in therapy. The spikes on the bottom of the page where it shows those, all those little spikes, that's an early refill where they're getting a 30-day supply, maybe every 28 days. They're getting it, a couple days before they run out. And if there's a gap, it's like, okay, they had a few extra days left because they've been getting, as a 30-day supply every 28 days for the past couple months. Now they may have a 4-day, what looks like a gap. They're just using their supply at home. The darker the tint indicates overlap in therapy, but overlap may or may not be a problem. It might be 2 different strengths of the same drug to get individualization of dosing, or it might be that early refill. But this nice little chart shows you, who's prescribing what type of drug. All the reds are opioids. All the blues are the sedatives or the benzodiazepines. And an overlap between sedatives and benzodiazepines, that potentially could be problematic as well. You have to look at the individual situation. So you have this nice little chart. Next slide, please. So now you get the line item detail that is used to build that color-coded graph and what's used to build the risk scores. So each prescription is itemized. It shows the drug, the quantity dispensed, the day's supply, the prescriber, and the dispensing pharmacy. All of this data is what the pharmacy reports to us. They do make errors in their data entry sometimes. A common error, now I shouldn't say a common error that we see. I don't say that this commonly happens, but we only get the questions on the problem ones. You have a Dr. Sarah Johnson. There are several Sarah Johnsons in Ohio. Some are MDs, some are DOs, some are nurse practitioners, some are physician assistants. If the pharmacy enters the wrong Sarah Johnson, we have no idea that it's the wrong Sarah Johnson. We publish what the pharmacy told us. But that's where, like everything's from what the pharmacy reports to us. Any errors would have to be addressed with the dispensing pharmacy because they're the ones who have that original prescription. But this is, I call this kind of like the grocery list. The The individual prescriptions, that's your grocery list, the same way I go to the grocery store and I buy, all the different products. The NARCS care helps take that products, and they're making some assumptions. Am I taking all these ingredients and making lasagna, or am I taking all these ingredients and making something completely different? And the same ingredients can make lots of different things. Think of things like, cookies and cakes have basically the same ingredients, but it's how you combine them in what proportions that make it a cookie or a cake. But the line item detail is where it all starts. Next slide, please. So medical marijuana is also included on a patient's OAARS report. The dispensations will say either tier 1 or tier 2. It may have additional information such as it's a gummy bear, a cookie, etc. in the drug description. Law enforcement officers, prescribers, and pharmacists, when they run a patient's report, they get the full report, including any medical marijuana if it's on there. When an employee of a medical marijuana dispensary requests a patient's OAARS report, they only see the medical marijuana dispenses. So a medical marijuana employee has no legal authority to see what other prescription items that patient is getting. So medical marijuana employees only see medical marijuana. Everybody else, again, like law enforcement, prescribers, pharmacists, they get the entire picture. Next slide, please. And then at the bottom of the report is a listing of the prescribers, but not necessarily the office at which that patient was seen. Prescribers may have multiple offices. The only information we get is the doctor name and their DEA number, and that gets translated into the address that the DEA has on file for them. The pharmacy addresses where the patient has gone, that's also listed on here. So that's at the bottom of the report. So you can see what pharmacy did the patient go to, what doctor did the patient go to. So if somebody has a question about it, they can actually call that the right prescriber, or the prescriber that was reported to us as being the right prescriber. Next slide. So remember we talked about those red flags, and you wonder, okay, how many is too many? Just because a patient has prescriptions from multiple doctors does not automatically make them a doctor shopper, okay? Prescribers may refer to, prescriber number 1 may refer me to another prescriber. Prescribers who work together, that's a very different situation than prescribers who are completely unassociated. Patients may realistically go to both their doctor and their dentist within a short period of time. An example of this, it's a personal example. Several years ago, taking a nice healthy walk outside, and I tripped on the sidewalk. And yes, I bruised my pride, but I also broke my arm during the process. So my first stop is at the urgent care. They offered me something for the pain. They told me now I need to see the orthopedic guy. I go to the orthopedic guy. They say, you're going to need surgery. Do you want anything for pain? And I say, but before we can do surgery, you need to have a checkup from your regular general practitioner. So I go to that person and they offer me something for pain. So within a 4-day time span, 3 different providers offered me something for pain. Fortunately, I didn't need any of it, but there's a reason why I went to 3 different prescribers in 4 days. That does not make me a doctor shopper. So those are things you have to think about. That's why having 3 is not automatically a doctor shopper. 2 prescribers might be too many. I'm going to doctor number 1 to get drugs, and I'm also going to doctor number 2 to get those same drugs. And my purpose is, my intent is, I just want drugs. So 2 could be too many if the purpose is for an inappropriate purpose, for intent to deceive. Next slide. Same with going to lots of pharmacies. It's not illegal to go to a different pharmacy every time I need a prescription filled, unless the intent is to try to deceive again, okay? Before PMPs existed, this was much easier to do. Now with our database and the requirement to run an OAARS report on a patient, procurement of drugs by deception is a much harder reality. There are many reasons why people go to new pharmacies. People move, not every pharmacy carries every medication, not every pharmacy participates in the patient's insurance program. Maybe I go to a pharmacy close to home, and the next time I go to a pharmacy that's next door to my workplace. So once again, having multiple pharmacies is not automatically a red flag. It's just something to think about. If I'm driving 200 miles to get a prescription for Valium, and I tell the pharmacist, gee, there's not a pharmacy between here and your place, 200 miles away that carries Valium, that's a red flag. That doesn't settle right. That gives a pharmacist heartburn. Running that OAARS report, where are they going? Are they traveling all over the state to get something that's generally readily available? Next slide. So we have all kinds of stuff on our website. Remember, there are basically two different websites, and I know that's confusing. There's a website where you would look up, or a prescriber would look up a patient, and then we have another website that we manage ourselves that has a lot of other information and resources on it. And when people ask us for reports or for data, this is where we send them, to our website. And there's that blue ribbon across the top where it talks about the different tabs, reports and statistics. And this is one that's fun to play with on your own. You're welcome to play with all this. These are all things that are available to the public. You don't even have to log into OAARS to get this information. So next slide, please. So like I said, there's just tons of different reports. I can't go through all of them. This is where you are welcome to play with this. But our OAARS administrator is a self-proclaimed data geek. And he built all kinds of things and shows it in the same data in different formats. It's, whatever is easiest for people. People have different preferences on how they want to see it. So you're able to look up a variety of different reports. The one I selected here was opioid prescriptions by quarter and county. And over where I have the check marks, you can select if you want opioids, if you want sedatives, that's an option. If you want stimulants, that's an option. And then you can select the measure, how many prescriptions or how many doses per patient or how many patients. So there's all kinds of ways to take the information and slice and dice it and aggregate it to fulfill whatever you're trying to find out here. It will not give you the 10 top prescribers of a stimulant in the state because that would be identified data. All this information that you're able to get is all de-identified. Some people like it in a chart that's shown here, like a little, little spreadsheet chart. Next slide, please. Some people want to see it in terms of a map, a color-coded map. So this shows the opioid doses per 100,000 residents. Over on the right-hand side, you can select your date level, you can select your county, you can select your drug category. So that's why I say it's actually kind of fun to slice and dice. Once you pick your parameters, you do have to give it a few seconds for it to generate that data. These are not static reports. If you were to run a report today, you may actually get slightly different information than if you ran that exact same report in a week from now, because we have new data coming in. So it's a constantly evolving type of picture that we have here. So those are these interactive reports that are available on our website. We refer people to these frequently. They are updated approximately, I think, wait till like the end of the month when we have the data for that month. Okay, I'm going to turn this over to Kelly, and you get her for a few slides, and then I'll wrap it up at the end.
Helps if I unmute there. For everyone, you don't have to hear me for very long today. Most of this is the Terry show this time. She's the real expert, but we thought we'd break it up just a little bit. And I'm just going to talk about the common gaps in OAARS usage, which I think for you guys is what we're waiting to hear, right? So it's my understanding that There's some frustration with the current grant that you guys have to meet some parameters, and we apologize that OAARS is such a wonderful system, but also you're welcome. But the state of Ohio has built a lot of laws and rules and regulations into this, and we have been at the forefront of this for many years now. And so there aren't a lot of gaps, but in every system there are gaps. And so we'll talk about here just briefly the main gaps in the OAARS usage. And so the first and most famous one is going to be the 7-day rule. Prescribers have to check OAARS anytime they are, as Terry talked about during the first session, anytime they are dispensing a opiate or a benzodiazepine. And that's not the whole rule, but you can go back to that rule, which is 4731-11-11. That's the Ohio Administrative Code. And so in that same rule, 4731-11-11G, you're going to find under G the exceptions. When do prescribers not have to check OAARS? And you'll see that if a prescription does not exceed 7 days, if they are going to write you for a prescription for up to 7 days of an opiate or a benzodiazepine, they do not have to check OAARS unless you exhibit signs of addiction. So if you come in and you're a step away from you know, an overdose yourself, technically, if they're going to write you a prescription because they see those signs, they have to check OAARS. But aside from that, if they're writing you from any under 7 days, they do not have to check your OAARS report before they write your prescription. We most commonly see this with dentists, oral surgeons, and ER docs. You know, the slide says so few pills, it can't hurt anyone. Why request a report? Sadly, this is still a view that's out there. I'm only going to write them a 6-day prescription. It's not, I mean, what's the big deal? Well, the big deal is if you write them a 6-day prescription and then the next doctor writes them a 6-day prescription, the next one writes them a 6-day prescription. Now the only person in that chain that you're relying on to stop the issue is the pharmacist. And so this is a team effort. It's not up to just the pharmacist. And so it's a pretty big gap, a pretty important gap, but there it is. There's the gap. It's not to say they can't, right? Anytime a doctor is going to write a prescription for a controlled substance, they can check OAARS for that patient. Anytime you're their patient, they can check OAARS. So it's not a, you're not allowed to check. It's a, you don't have to by law. So lots of prescribers, lots of hospitals have policies in their ERs now that say they have to, even though the law says they don't. Their hospital policy is that they do. So that's not to say everybody hides behind this rule and doesn't check OAARS for 7-day scripts, but there are still people who do not check OAARS for 7-day scripts. I'm going to say your largest population of those people, anecdotally, will be dentists. Okay, so then some other common gaps in OAARS usage. I talked about before, it is a team effort to catch the drug diversion and to catch people that are doing deception or who are addicted. And team effort would be the doctors, the pharmacists. And so a lot of times, you know, when I have a case and I'm out interviewing docs, because that's part of what I do, they'll say, well, I mean, I didn't do anything wrong. That's not my fault, you know, that they're an addict and I didn't catch that. And well, no, but, you know, do no harm. And it is your job to be responsible for your DEA number and for the release of those drugs. And so, you know, what we would like to see, but is not a requirement, is there's a couple reports that the prescribers can run and do get that will help them catch this if they would just look at them. And so one of those is an MyRx report, and I'll show you what that looks like. Although it's kind of hard to see. Can we just show slide 66 for a second? Sorry, I'm going to jump ahead here. I should have put it next. Okay, so that's a MyRx report. Obviously the names are blurred out, but this is what a doc can run. And it will show all the prescriptions that were dispensed under their DEA number, and the patient name and what the drug was and where it was dispensed. And so the idea is if they were to run this regularly, which they can, and either they or their delegate, which might be, you know, their office manager or their MA or their whoever their delegate is, might run this and look against patient records and say, oh no, we didn't prescribe tramadol to Joe Smith. What's going on? Then they need to call the pharmacy, talk to the pharmacy, ask for a copy of that script, see what's, you know, going on, and then it maybe alert the authorities if in fact, it is not their prescription. Occasionally, we want them to call the pharmacy first, because occasionally what will happen is you have a pharmacy technician who is exhausted, they're overworked that day, whatever the excuse, they misentered the wrong doctor. They accidentally wrote the DA off the prescription in front of theirs and entered the data wrong, which can be corrected. And that is not a crime, it's an accident. And so that's why we encourage the doc to call the pharmacy and clear it up with them first before they call law enforcement, to verify it really wasn't a data entry error. If you just go back one slide then, Casey, sorry. So these are the things, again, that the MyRx report shows. They can show the prescriber a list of the prescriptions that are filled, that will show the patient, the pharmacy, and the drug. Not all the gaps for that is not all the prescribers know how to access this report or understand what its benefit is. So when I go out and talk to prescribers, a lot of times for me, it's after the fact, right? They already have had patients that they could have maybe helped by writing this report regularly, but nonetheless, I stop and educate them. Occasionally I'll try to do it if I'm out on inspections for other reasons, educate the docs. Hey, do you know what this report is? You can run it. Are you running it? You find a lot of good docs are like, oh yeah, I check mine monthly. I stay on top of that. I don't want anyone using my DA, like it shouldn't be used. And then you have others be like, oh, what? And I have to hook them into calling someone in Columbus, like the wonderful Terry, to send them an instruction sheet or something on how to do it because they just don't know. So that's that one. And then the other one, if you will go down to slide 67, there's another report called a PMP prescriber report. And this is a report that's auto-generated by the software vendor, which is currently OAARS. And you can't just ask for it, it just gets sent to those doctors. And it provides an overview of their prescribing, broken down by opiates, buprenorphine, sedatives, and stimulants. And then it shows a number of OAARS patient searches that they have done. If you want to go to the next slide, this is what that looks like. So, you can see in the top right, it tells them how many prescribers are in there. Terry, I don't know if that's a specific area or there's, specialty, it says specialty, never mind. Within your specialty, so it tells them that, and then what time frame this for, and it'll give them like a statistical overview of what their prescribing looks like. So they should be able to self-check, right? Like, oh if my prescribing is through the roof compared to all the other prescribers, okay, maybe I ought to evaluate my own prescribing, and or that shows like, are you regularly checking your own patient OAARS? Which is a requirement of law. It'll show how many they've done, that kind of thing. So I think that's pretty much, I'll look back here and see if I did. No, I think that's pretty much it. I mean, the other gap that we say of what is not on OAARS, but this is not something that we can control or gap that we can regulate, is just that treatment dispensing. So at like a methadone clinic, for instance, they do not report to OAARS those drugs. It's my understanding that now there is kind of a tickler at the top of the OAARS report that will tell someone who runs it that this person is receiving treatment, but it doesn't, and it tells them where, and that's it, but not the drugs. And that only stays on while they're in current treatment, it's my understanding. But that is part of CFR 42. That's a federal rule for, patient protection of people in treatment. And so that's not something that we would consider an adapt. It could be a gap that's like, could be identified to change or anything. So that's pretty much it. Terry, feel free to jump in if there are other gaps that I missed there.
The other thing I want to bring up on slide 68, which is the one above where you're at now, that one, for the prescriber reports. This report has evolved a lot over the last 4 years based on feedback from prescribers. And, first time these things came out, let's face it, we don't know really what people want. But one of the key things on here, the reason it's not, this is a report that's not available on demand because it compares prescribers to others with their same specialty. So it's not like it's just going to be, this is the number of patients you have. It's going to be your dosing with your patients. It's how do you compare to other prescribers with that same specialty. And then we got all kinds of friendly feedback. And I say that with a little pinch of salt. How I work 5 days a week. And so of course I'm going to have more patients than somebody who works 2 days a week. So now the report really is per patient. So we took away that concern that you're comparing me to people who work far less than me. So it is a per patient analysis on here. So this report does evolve. It's what we have now. If we can improve it for future iterations, things, it may change. So, but the big thing is it is per patient, and it does compare them to others. It compares that prescriber with others in the same specialty. So it's not going to compare an orthopedic surgeon with a pediatrician. So, and the specialty is told, they tell us what specialty they are based on in their OAARS profile. They self-identify saying, I am a pediatrician, or I am an oral surgeon. So it keeps it apples to apples. All righty, next slide, please. So when people do have questions, we tell them to contact the pharmacy, but they don't know that until they contact us first. So, we get a lot of questions through our support box. That's the place to start. If people have, or if a report shows up as, Terry Gitman got married and now her last name is, Smith, that would be 2 separate profiles. The name changed, and OAARS does its best to group those patients together, but it's not perfect. So if Terry does have 2, or you suspect they have more than 1 profile, the doctor can always email us, and we just need the patient names, date of birth. We can merge those. If we can find them, we can merge them. Sometimes you have more than 1 patient on 1 report. So the converse of that, hard to believe this, but there is more than one John Smith with a specific date of birth in this state. Like I said, it's not a perfect system. We do our best to keep those separated, but there is no guarantee that as new data comes into us, literally on a daily basis, that it's going to fall into the right bucket. We can separate them based on cities, but we need to have that information to be able to do that. Any account updates from a client, an OAARS client, if they've had a change of email, change of role, all those things need to come to our support box. We will make those corrections and address those things on an individual basis. If it's the wrong prescriber assigned to that script, we don't know that it's wrong. That's where we tell the prescribers to contact the dispensing pharmacy. When I look at our support box, I would say 90% of our things fall into this category, or simple things like I need to update an email on their account. I need to update, they've gone from they were an RN as a delegate, and now they are an APRN. We need to change their role. Password resets when they're not able to do them themselves. There's a link on the front page to do a password reset themselves, but we all know how technology is. We know how email blocking goes. So sometimes they're not able to do it on their own, and they have to contact us. So, and us is 1 or 2 people. So please have them be patient with us. It will take us a little time to address all those little corrections that need to be made. Next slide, please. So if you haven't had enough of us already, this is how to reach us. If you have specific questions, we're always happy to educate. That's what we're here for. That's one of the missions of the board, is to educate. So that's how to reach us, and that general support box is another way to reach us as well. And next slide. So I think we still have about 10 or so minutes left on our time frame. So if there's any questions, I'm going to defer to Casey on how she wants to manage those. If it's open mic or if it's through the chat box. So I'm going to defer to her on that.
Sure, thanks, Terry. We can do both. And it looks like, so if you have questions, feel free to unmute and ask, or drop them in the chat. We have a couple of questions that have been shared already, and I just want to highlight those. We had a question about allowing physicians to access OAARS for overdose fatality review boards. And Kelly, you've shared a link to some of that guidance. Is there anything you'd like to speak to about that?
Nope, that link will you know, the link is very specific. It'll tell you who can access it and how, and it's very specific to that exact question. So I think that'll cover it, as long as you guys can all see and click that link.
Thank you, Kelly.
Working? Did you try it?
I have not, because I'm afraid to click on anything that it might.
Whoever needed it, if you want to make sure it works before we hang up there.
Thank you.
One thing I can add to that, that is limited to coroners, physicians, or pharmacists on a committee. So it's not general information available to anybody. That
It says that on that.
Okay.
That Cameron did a pretty good job with the guidance. It lists who can do it and where the law says who can do it.
Yes.
Great, thank you. We have another question in the chat. For the county-based data, how is the data assigned to the county? Is it based on the prescriber's address and county, the pharmacy's address or county, or the patient's address or county?
That's a very good question. I'm not the data guru behind that. My gut tells me it is based on the patient's zip code, which because we don't get county. When a pharmacy reports a script to us, they don't tell us what county the patient lives in. They just tell us their zip code. So, and then we have the geocaching thing that tells us, zip code 43209 is Franklin County. But keep in mind, every time I go to Costco to fill a script, they don't ask me if I've moved. They have the county or the address that I gave them when I first went there. And if I've moved, they wouldn't know that. They're not mailing me anything, so they don't really care where I live. So it's, the information that the pharmacy is providing to us can't guarantee that that's always current on that patient. If they're in that same zip code anymore.
I can't speak for them specifically, but if that's not, you might be able to run it for a prescriber, because we do collect prescriber information when they're dispensed. However, the prescriber information is based on the prescriber's DEA number. So if my DEA number is in Miami County as a prescriber, but I also work in Montgomery and Preble County, and I only have one DEA number in Miami, anytime I write a prescription, it's going to show under my Miami County DEA number, if that makes sense. So you could possibly, if it's not already on that site, ask for a by prescriber type of breakdown of statistics, but that's going to be even less accurate because of the whole, if I could be a prescriber who works at a hospital in Montgomery County, but my DA is for my house at Miami, if that makes sense. So if it were being tracked by the prescriber, it would be a lot less accurate information.
And that's what I'm almost willing to bet lunch that it's based on the patient's zip code.
Thank you both. What other questions do people have?
I have a question.
Yes, go ahead.
Do you think that some of the doctors, maybe like in the ER and stuff, that some of their reluctance to input patients and different things could be somewhat of the look of bias? Because my opinion is that I personally think OAARS is needed, because I work in the overdose situation. And I see that how good the system is, but listening to some of what is being said and looking at patients and saying this is an issue or this could be an issue here. Even here, some patients are pointed out to be that patient that probably is pill seeking. I don't know, it seems so, it could be biased, and doctors can start to be labeled, especially in places like the emergency room, for seeking out people.
Well, let me just say, we want them to be biased. If you see an OAARS report and it's got way too many pills on it, we want you as a prescriber to stop and say, I'm probably not going to write you a prescription because you are getting one every 7 days from a different doctor. But anecdotally, and Terry, correct me if I'm wrong here, but I think most of the reasoning behind the 7-day thing is, they're saying, we're only writing a 7 days prescription for a one-time acute thing. And so, if it's a procedure or an ER visit or a dentist, it's a acute painful thing that it's necessary for, and it's just a one-time thing. And then also a lot of times in the ER specifically, if you're asking about that, you'll hear people say, well, it's busy and it's fast-paced and it's emergent and I just don't have time to stop and review this whole thing just to write them a prescription for 3 pills. Now, integration has fixed a lot of that. A lot of their systems just do it for them now, and that's why a lot of hospitals say, you know, we integrated it, so that's not a barrier anymore. So you have to, kind of thing, from the hospital standpoint. But that's more what we hear as a barrier, as it takes too much time, and to what end? Because I'm only writing them 3 pills.
Right.
And
And I get that in the emergency room. So what are the dentists saying? Because for me, I like the purpose of a dentist writing 5 to 7 days of Percocets or something for a pulled teeth is useless. Like, that's completely useless. And they have the time to even do more teaching than they do in the emergency room.
Interesting you bring up dentists. We have had, and I don't know if this is from the dental board or from the dental associations or where it's coming from, we have had a huge increase in the number of accounts by dentists. So they're using it a lot more. I mean, literally within the past, I say 6 months, than we ever saw using it before. Their rules haven't changed, but I think they're getting a lot more educated and encouraged to be running reports on people. I just the number of accounts that we've created for dentists. I mean, I noticed it, a couple months or about 3 or 4 months ago, and it was just because like one of those little oddball things I happened to notice. But then I started, it's like, wow, this is continuing. And from what I've heard from somebody who's a dental investigator, she said, yeah, we're really encouraging them to use the system even outside of even more strictly than what the rule says that they have to do. They can only enforce the rule, but dentists are really being encouraged to check it more frequently than they used to be. So that's a positive sign.
So, and what we're telling you is, no, we can't give you any reason that gap is necessary, that they don't have to, but we can't really speak to that. You're on to something.
Thank you for the question. Any other questions? Well, while you are forming your words there, I will go ahead and share the link for continuing education evaluation. So if you are interested in getting CEs for attending today, you will need to fill out that survey. You're welcome to do that now and use that link, or we will send out a follow-up email that will include the survey link so that you can get your credits. Terry, I had a question actually, and you may have said this, and I was just busy finagling slides and the waiting room stuff. So, but on that OAARS report where it notes the overdose risk score, can you talk a little bit about how that score is calculated and how what guidance is available for just what that score means, what's high and what is expected?
Okay. Yeah, I can address that, or I can do my best to address that. That's on slide 53. So if people are wondering what you're talking about, that's this is that algorithm that was built. It takes it was actually built, oh gosh, maybe 10 or 11 years ago-ish by a doctor who is also like a data and IT computer guru. And he built included different factors, like how many doctors, how many days supply, how many days of overlap, relative doses. And you took all these different factors and built this algorithm with it. It ranges from, the overdose risk score ranges from 0 to 999. The last digit tells you the number of, something like a number of active scripts. And I know this one shows a 0. So it may not be that they might not have any active scripts at that time. And active means I got a 10-day supply within the last 10 days. A 10-day supply given 20 days ago, I'm not going to have, in theory, I wouldn't have any of those, that supply left. So that script's no longer active. But there's somebody, it says algorithm, the higher the number, the more likely of a problem. High dose of opioids will definitely increase that number. High number of scripts of opioids can affect that number, and the number changes frequently. It's not like a credit score that it takes time for it to adjust. If I had a high dose of an opioid, a 10-day supply, and that's from 2 months ago, is going to be a much lower score than that same prescription filled yesterday. So as time moves on, as old scripts fall off, the number goes down. As new scripts are added, the number goes up. It fluctuates. It fluctuates as data comes in. We've even had people say, hey, this morning I ran the report and the risk score was 100. And tonight I ran the same report and the risk score is 200. What's wrong? Well, we got a new script in reported to us sometime during that day. So it's very fluid. It's not saying that the patient will overdose, but it's just there's that higher potential based on doses of medication, days supply left, how many doctors they go to. It's all kinds of different factors put into this pot. They run the numbers. There's no standard on that overdose risk score to compare it to somebody else's assessment, but it's just saying for this patient using these numbers or this information, where does it land? It's all relative.
Thanks,
And that's
Jen.
that's what that link where I've highlighted where it says explanation and guidance. It explains how that score comes about.
Thank you. Any final questions? All right, well, I want to thank everyone for attending today. As I mentioned at the beginning of the presentation, we will have 2 more sessions, and that information, registration links and information about those sessions will go out in an email after today's webinar. But those will be on March 31st from 12 to 1. That session is on interpreting county level OAARS data. And session 4 will be on April 28th from 12 to 1, and that will be about using OARS data for strategic planning. And our friends at Prevention First and Tessa Miracle from OSU will be leading us through those topics. So again, thanks everyone for attending, and hopefully we will see you next month.